Sounds like of course. I'll do this. Good. We're good to go. The first. If I have one. Can use numbers. That's your specters on as well. Good morning, everyone. Thank you very much for the early start. I hope you've all got full cups of coffee or tea in front of you. There is lots and lots of food out there, so please don't be shy when filling up your plates to keep you feeling fresh for what is sure to be a great couple of hours here this morning. Very similar kind of format to what we did yesterday. We've got a couple of extra presenters, which is exciting. So we're going to be moving through things a little bit quicker. And we do have a number of people that are going on day tours today. So we will make sure that at 10 o'clock we get you guys out of this room to either explore the sights and sounds of Bali or maybe put the feet up and have a little nap. Not too much housekeeping. That was pretty much done yesterday. I put shoes on this morning, so I feel very formal. It's about as formal as I get. But please, look, Dylan and I, our backgrounds as paramedics, not conference organisers. So if you do have any feedback during the week, anything that you see that you'd be like, hey, this would be cool if you did this different, or why don't you do this? Please have a chat to us, because we really do want to take that on board and continue to, I guess, grow these events and offer new destinations and places. For the eagle eyes in the room, you'll see the timetable and the list of presenters we have this morning. We've just done a little shuffle, and Elyse has been very kind to step in first. She's a keen bean and just wanted to get it done. No, she's helped us out of a little pickle. So yeah, let's give a warm welcome to Elyse Phelps onto stage for our first presentation.
Good morning, everyone. Thank you for being up so early to be here today. I'm absolutely prepared and organised to go early. It's not a problem. Good to see you sorted, mate. What a time. You okay? Welfare check? Yeah. Good. Good morning. My name is Elyse Phelps, or Elyse Cooper Phelps, or Coops, as some people might know me as. And today I'll be presenting on a condition very close to my heart, not because it's happened to me, thank God, but because I have a special interest. It is high pressure injection injury. Before I start, can anyone raise their hand if they have a vague awareness of what I'm talking about when I say high pressure injection injury? Good, good. All right, we've got some awareness and some non-awareness, which is why I'm here, because this is a really life-threatening condition, and it's actually getting more and more prevalent in recent years. So I'm here to talk to you about it, and hopefully we can try and detect these injuries early and get good patient outcomes. I've made a video instead of a PowerPoint, and this is my first time playing it, so apologies in advance if we are a little bit out of sync. Mesh Education, the industrial series. This is just the logo from my business, which is mining and energy sector healthcare education. So I've got a bit of a special interest in what we call industrial healthcare. I don't know if we call it that. It's a bit of a niche section of healthcare. And what I'm talking about when I say industrial healthcare is paramedics or healthcare providers, nurses, doctors working in the industrial sector, whether that be offshore in oil and gas or mining onshore, or even down like Kwinana industrial area for our East Coasters, that's sort of in the south where we keep all of our dangerous things away from everyone else. Has anyone worked in the industrial sector before, whether emergency services or, yep, cool. Been in the Pilbara before? Yep, bit going on out there. So a bit of my background, I started my career in the ambulance service. I went on to dabble in nursing and education. I created my business to help create awareness around this particular niche of healthcare, because what I found when I started doing industrial paramedicine or working out in the mines as a paramedic is that we've got this job role that's so incredibly diverse. So we've got someone who may have only done potentially a Cert 4 in healthcare, and they're put into this position, or regardless of your qualification, to be honest, you're put in a position where you're working firstly remote with limited resources, but you're also taking on a multitude of roles. So yes, you're ready for emergencies, but mining tend to be quite safety conscious, yeah? So the likelihood of an emergency is not necessarily super common, but what we do get is people coming in with exacerbations of their chronic illnesses, lots of wound care, lots of skin conditions. And for a lot of us, especially pre-hospital providers, we don't really dabble in too much of primary health care in terms of like, oh, you've got a sore tummy, you want to go to hospital? We'll take you, no worries, hop in. Right? We're not sort of super versed in differentiating between a migraine and a headache and, you know, really delving into a abdominal assessment, right? Because we'll take you to hospital. You know, we've got nurses and doctors for that if you're a paramedic. But now all of a sudden we're giving this massive responsibility to people to do not only emergency care, but primary health care, including wound care and skin conditions, also occupational health, right? We're doing return to work stuff. We're making sure these people are fit for work. And I really, when I got out there, I was like, wow, how are we prepared for this role? And to be honest, I don't think that we are. So I went on to do a bit of research to find out who's providing this education. And to be honest, there's not a lot. So my passion is helping sort of bridge the gap between paramedicine and nursing to make sure that people working in these industries are really prepared for the kind of, well, the vast majority of conditions that they might be presented with. So high pressure injection injury is something that is really commonly missed, and we'll delve into that shortly. And I think it's really important that especially as us emergency physicians, where we're the first point of contact with the patient, that we can detect these early, because they do lead to amputation, and especially amputations of fingers and hands. And these are our labour, yeah? I digressed. Let's see how long this... goes for. It'll transition in just a moment. Right, high pressure injection injury presentation overview. I'm going to talk about what it is, talk a little bit about etiology and the demographics, bit of pathophysiology, assessment considerations and treatment options, bit of a literature review, and the importance of education. Now, I'd like to really drive home that I am not a doctor nor a surgeon nor have any experience in that realm. So for any of the doctors in the room, a lot of the advice or suggestions I've put up in this presentation are based on the literature reviews in the last 4 years from 2020, and there's been a huge increase in data. So I'll just be providing the recommendations of what is suggested based on best practice. Okay, what is a high pressure injection injury? Thanks for asking. Let's get into it. As the word suggests, it's high pressure, it's an injection, it's a form of trauma caused by the injection of a substance or gas into human tissue through a high pressured mechanism such as industrial hydraulic lines, paint guns and cleaning equipments. Anyone ever clean the driveway with a pressurized water machine before? Classic, high pressure injection injury. So the injury occurs when fluid escapes the hosing or trigger mechanism of the pressurized equipment, forcefully injecting the material through the skin and into the surrounding tissue. So because the injury generally occurs when the operator is attempting to wipe or clear a blocked nozzle with, while holding the gun or steadying it with their hand or palm, it often happens in the non-dominant hand. So they're using their dominant hand to operate the equipment, thus the injury most commonly occurs in the non-dominant hand. Rupture to faulty hosing is a second leading cause, injuring the operator, including during maintenance or testing procedures. So this is for a little bit of context. I want you to imagine a 1,000 kilogram weight falling from a height of 25 centimetres onto a small surface area of the body, such as the finger. This is equal to the force exerted by a pressurised substance at only 100 psi. So, perspective. Operational pressures for the kind of equipment that's used in the industry is from 600 to 12,000 psi, and the average of the injuries based on the lit review, the average exposure is around 4,500 psi, right? So that's a fair bit of pressure going into a really small area. So penetration of human skin can happen as low as 100 psi and from a distance of 100 mil away. So it doesn't necessarily have to be direct contact for this injection injury to occur. And I've got a cool video to show you shortly that'll sort of demonstrate what I mean by that. So, we as healthcare professionals may not be used to the term injection injury other than perhaps something like this, yeah? And I really need to drive this home because it's probably the most important thing I want anyone to take away from this presentation, outside of all the nerdy stuff, is that we need to understand the equipment involved, and you're going to need to ask lots and lots and lots of questions. And when we get into the demographics, you'll understand why. But the kind of people that, I don't want to say the kind of people, I'll get onto it shortly. All right, let's have a little look at equipment, because let's be honest, most of us have absolutely no idea. So, lots of equipment, attachments, plant components used in the industrial setting under high pressure systems to perform their allocated functions. Also, some of these pressurized oils or greases and even water is hot. Right? So we're looking at injections with potentially 80 degrees of temperature on top of the high pressure injection, right? So there's a bit going on there. So again, this is mostly just for us who are a little bit unfamiliar with the equipment to understand what I'm talking about with this, why we need to ask lots of questions. I'll be honest, I've had a lot of people come into me in the MindSight clinic before, and they'll try and tell me what's happened to them. And I literally have to say to these people, I'm going to need you to go back a little bit and maybe draw me a picture, because I have no idea what you just said. That's like me going to them and going, oh yeah, pseudostratified ciliated squamous epithelium in the larynx, in the kidney tubules. They'll be like, what? That's how I feel when I have a fitter come into the clinic and tell me what he was doing with some piece of equipment. I have no idea what he's talking about, right? So It's really, really important that we understand what kind of job role or what task they were undertaking when this happened. So I've put some examples of equipment up here. Some of this stuff you guys might have at home already, but think of it on a much larger scale when we're looking at things in an occupational setting. Injected materials. This is huge, and this is another question you're going to have to ask and get them to write it down and ask them to spell it and then Google it or get out the safety data sheet, call the poisons hotline, because some of the stuff that comes out, I'm like, right, yes, of course, that stuff, yes. All right. It's also really important because it has significant determination on the severity of the injury sustained. So the toxicity and viscosity of the material can affect the rate of tissue deterioration and have secondary cytotoxic and infectious complications at the injury site and systemically within the body. So there's hydrofluoric acid is commonly used in the industrial setting. And with that, we're looking at absorption, immediate absorption of the chemical on top of the injection injury. And then we're looking at hypomagnesia, hypocalcemia, and then cardiac arrhythmias as a secondary result. So there's a bit going on. We need to ask these questions. Not to mention the pain associated with that. So here's some commonly injected materials: hydraulic oil, paint, transmission fluid, terps, diesel fuel, cement, grease, water, air, ammonia. Also, epoxy resin has been in recent years, has been a little bit more frequently used. They've used the diversity of epoxy resin in how we're using it and what we use it for has really expanded. And I've noticed in the evidence there's been a huge increase in the case studies of epoxy resin paint injection injuries. I've got some gnarly images to show you shortly about that. So solvents increase the amputation rate in the affected area from 48% up to 80%. And this is huge, especially when we're talking about hands, like I said before. This is our labour. Early recognition, appropriate referral with a potential high pressure injection injury is vital, particularly those in remote or industrial settings. And why is that? Well, firstly, in a remote or industrial setting, we've got the equipment, thus a higher exposure rate to the potential injury, but also we've got a logistical nightmare, right? And we might have, say, an emergency services officer that might be a little bit green in the role, looks at the injury, doesn't think it's too much, and from there, we have a delayed treatment time, and then on top of that, we might need to have road and air transport together to get to a tertiary facility. Then we're delaying treatment time even further. All right, demographics. I said I'd talk about this a bit. So it happens mostly in males, sorry guys, average age mid-30s, in laborious job roles, and a range of experienced and inexperienced workers. So we've got people as young as 18 who are brand new into the role. Maybe they're a bit nervous or unfamiliar with the equipment. They're trying to do the right thing. They get an injury. Then, oh my goodness, it's my first week on the job. I just got a FIFO gig and I've got an injury. So we have something called a poor reporting culture. Also in the mining industry, we have a thing called shirts versus contractors. Has anyone heard of that before? Yeah, shirts versus, yeah. So if you've got a shirt, you're like, yeah, I work for the company. And if you're a contractor, you're like, please keep me here. I'll do anything to stay here. I know you can get rid of me at any point. So if you've got a contractor with an injury, they're even less likely to report the injury because A, they're there for a short period of time. They want to get the job done. 2, they're scared they're not going to get called back if they say I've got an injury. And 3, sorry guys, I don't want to bring up toxic masculinity, but it's like, oh, I've got a boo and it doesn't look real bad, so I'm just going to keep it to myself, right? Anyone? No? It's true, right? It's real. It's real. All right, it represents, based on the data, 1 in every 600 reported hand injuries. So it's not super, super common. There's an average of 156 near misses reported annually, and this is in Australia, based on data from 2016 till present. Approximately 20 incidents per year in the mining industry alone. So that's actual injuries that are occurring, with underground coal mining the most frequently encountered in that industry. Anyone worked in coal mining before? Over in the coal bowl in Queensland? Those guys are cowboys, man. They are crazy. I've never been so busy in my life. Right, high-risk job roles, fitters, maintenance workers, boiler. I'm not going to rattle them all off to you, right? I've put a little asterisk next to farmers. Any idea why? Is anyone from the country, grew up on a farm, middle of nowhere? Anyone? Any ideas? Shout out. Why do you reckon farmers might be at risk of a high pressure injection injury? Yeah? Yeah, they make lots of stuff themselves. Yeah, absolutely. They do. Yeah, they're pretty good at it too. Hey, multi-skilled. Yeah. Yes, working alone, absolutely. And if anyone knows a farmer, oh, it's not a big deal. Don't worry about it. Yeah. Also, they have livestock, and those livestock get vaccinations. So there is a cohort in the data of high pressure injection injuries from farmers, not necessarily from maintaining their equipment, but injecting themselves with inoculations meant for cattle. Right, it's a pretty big dose. It's a large dose. It's not 2 mil. It's more like 50 mil or more, right? And they're just jabbing it in. They miss a spot, and they have the guns for it as well, yeah, the pressurized guns to inject, because they're doing like 50 in 1 minute. They're like right the way through. So we've got this cohort of high pressure injection injury from vaccinations. Wild, huh? Definitely not going to catch any of those diseases anytime soon, that's for sure. And I've put an asterisk next to emergency services staff, and I can see one in the room already, and in particular, our water fairies, firefighters. Why are emergency service staff at higher risk of high pressure injection injury? Use them big hoses, them big pressurized hoses, yeah, connected to a big heavy tank that squirts things out, wet stuff on the hot stuff, right? So these guys are also working in an emergency where your adrenaline's pumping a bit and you're running to do your job real quick, otherwise the cat can't get out of the tree. Sorry, no offense. Right, because the house is burning down, big deal, something's going to blow up, right? So they're working under pressure and with equipment under pressure, pun intended. Cool. So lots of these guys are working also in the city, but a large population are based in the industrial sector. Right, pattern of injury. 2/3 of all reported high pressure injection injuries occur in the non-dominant hand. We talked about that. Frequently at the distal end of the index digit, pointer finger. Other commonly affected regions include the thumb, the middle finger, and the centre of the palm, but there are also a range of other areas that get affected by high pressure injection, including lower limbs and feet, the groin, that's unfortunate, abdomen, face, neck, chest, forearm, and eyes, also not ideal. So this is based on the studies. These are lower risk, lower incidence, but this still happens. Right, a little bit about pathophysiology. First of all, a visual representation. So the following video uses a gelatin block at a consistency similar to replicate human tissue. Now, these guys have done an experiment and they've used leather placed over the site of where the injection is going to take place. They've pressurized oil-based paint set to 600 psi and drilled a 0.4 millimeter hole in the hosing, and they've blocked it with Play-Doh. And they've recorded what happens. Check this out. See that? So imagine that's your hand. You see the force and the distance it travels as well. Now, this second one here that I've put in is from not direct contact, right? Not direct contact with the point of injection itself, but they've got a hose that's running underneath. Can you see the black hose running underneath? So here they've simulated faulty hosing equipment, and imagine that someone's resting against that, whether that be your forearm, another part of the body. And if you look at that, when it goes, huge. And another issue with this is you'll notice what happened to the gelatin after that occurred. Boop. Yeah, so think about like tertiary blast injury, yeah? Look at that. So then we're going to have additional injuries on top of the high pressure injection, which you'll be able to see in a moment, even though it's not as severe as the direct injection point. We're then going to have potential shearing of the tissues within as well, and secondary injuries related to that. Isn't that wild? And this is just from faulty hosing. It's got a little bit of a crack in it. We're not checking our equipment properly, and this sort of thing can happen. And it's getting more and more common, unfortunately. All right, stages of injury. We have initial injury, which can include burns, which we spoke about, chemical irritation, the inflammation stage, and secondary infection. Initial injury, we've got tearing or dissection, ligaments, tendons, and the neurovascular structure. The injected material will follow the path of least resistance, right? It's generally along the tendon sheath and neurovascular bundles, and it moves proximally until the motion ceases. The substance spreads through subcutaneous tissues into fascial planes. Of course, this is all dependent on the kind of injection of this. This is why it's important we ask about the substance. All right, we get immediate vascular compromise, acute and chronic inflammation, and acute compartment syndrome. So the problem we have here is that we can't see it initially, which is why we always have to have a high index of suspicion and early surgical review for these patients, because it doesn't look like much on the outside. And I've got some gnarly pics to show you in a sec. But the spread of the product can be quite significant. There's been reports of it all the way up to the elbow. So the prognostic variables, time from injury to treatment, and this is huge. The longer the delay in assessment, the poorer the prognosis and outcome for that patient. And again, demographics. Let's say you've got, okay, and I don't want to put anyone in a pocket here. Let's say you've got a 57-year-old male who is true blue Aussie, working in mining his whole life. He loves export. He loves his footy. And he loves to put his feet up on the couch. He's not much of a talker, right? He's got some communication issues in his relationship, right? And he comes into a hospital because either his supervisor or his wife's dragged him in by the ear, said, go and get it looked at. You've been whinging about this for 3 days. And he sits down in front of you, a healthcare professional, and you're like, hey, mate, what's going on? Oh, this finger is bloody sore. You're like, okay, well, what happened? Oh, I don't really know. Okay, well, what have you been up to? Oh, I was using this hose and it blew up, right? So you're going to literally have to get your shovel and dig with these people, right? Or imagine has anyone got teenage boys, sons, or know of teenage boys that are in your life? They don't talk much, they grunt a lot, right? And so you're going to be asking this guy questions and he's just going to be like looking at the floor like, yeah, no. We all know the type, yeah? So we really need to, as healthcare providers, we're going to have to put in the hard yards for these people to get the information that we need to understand the severity of this injury, because we need to know the force of the injection. So we're going to have to ask them, what was the PSI of the equipment, right? And us healthcare professionals like, the PSI, no hydraulic, what? You know? So this is why it's important we have a basic understanding of what we need to know to ask the right questions. We need to know the volume injected, or a rough idea of the volume injected, right? The type of injected material, the toxicity, right? Maybe we need to look up an MSDS. Is it at a certain temperature, if they know? The viscosity of the material. So grease, for example, versus fuel, right? Different viscosities. So grease might not inject as further up the arm or move as proximally as, say, something a thinner liquid like fuel, but there's a different kind of injuries we can sustain based on the chemical properties of what's been injected, right? Synovial sheaths, right, around the joints. If it penetrates into that, we've got otopora prognosis, the anatomy and distendability of the injection site, and secondary infection. The time between injury and surgery directly correlate with the severity of symptoms. Now, this is in every single article, journal I've read. It's all about time, and time is tissue. We need to get, what time did this happen? And we need to encourage people who work in these industries, if you've got a boo, it might not be just a boo, go and get it looked at, especially if you've got some reduced range of movements and pain, or they seem a little bit guarded about getting it looked at, right? So the average time from injury to presentation, 6 hours, and outliers of over 20 hours. Some of them were 6 months without review. And by that time, the substance has either calcified or it's become like chewing gum and stuck onto the tendons and around the joints. Gross, right? So time is super, super important. We talked about this earlier, time delays to appropriate treatment and intervention impacted by distance to tertiary healthcare facilities, particularly up in the mining industry or even remote metro areas, right? We need to take these people not to a peripheral hospital, they need to go to a trauma centre. Chemical injury and inflammation. So solvents, we talked about it earlier, extremely cytotoxic. So we get liquefaction of the tissues and lipid dissolution. Caustic substances, we talked about hydrofluoric acid, right? Stronger inflammatory responses and increased necrosis. Chronic granuloma formation, especially from waxes and greases. They're also carcinogenic. A lot of them have got carcinogenic properties. So then we're looking at a more chronic issue, long-term issue and exposure, particularly if it's been in there for a long time. These people are then looking at further complications and health issues down the track. The vasospasm, thrombosis and ischemia, especially with the compartment syndrome, right? We've got compression of the vessels to the distal vascularity. One moment. All right, secondary infection. Think about the equipment. Think about the farmer injecting the cows. Anyone seen a fly-blown sheep before? No? I won't bring it up. But let's think about how dirty some of this equipment is that's injecting in, right? We've got direct break of the external barrier, often polymicrobial infections as a secondary. Intensified by necrosis, and again, this is secondary to time. The longer the injury has been sustained, we're getting necrotic tissue, right? Then we're getting breakdowns, we're getting increased potassium. All of the data had gram-positive and negative bacteria frequently found on the cultures, polymicrobial. Systemic absorption and toxicity of the chemicals. Another reason we need to find out what chemical is it. We need to get our MSDS. We might need to call the poisons hotline. We need to find out what is the pH of this as well, because that's also going to affect the tissue degradation. Foreign bodies, there might be bits and pieces in there, and tissue displacement from the blast, which we saw in the video, yeah? So all these things that we need to think about when we're looking at this, what could be otherwise quite a fairly innocuous looking injury. This will transition in just a moment, I'm certain. Medical images incoming. You've all been waiting for it. There we go. So, in the top left there, looks fairly benign, yeah? Doesn't look like too much. Looks like something that a worker might go, should be right. Keep going. Good. The injury below, this one is actually over 24 hours, delayed assessment and intervention. And then the image on the right, the injection is not only penetrated just as a direct wound, but it's actually extended up the arm, right? I mean, we're probably going to do this to them anyway with a fasciotomy for treatment for expansion from compartment syndrome, but that would also be exceptionally painful, yeah? All right, this one is a 59-year-old male that was working with, this is diesel fuel injection. You can see the area of necrosis just below the third digit there. This is from a paint gun injection. This is epoxy. This case is really interesting. This is an epoxy resin paint injection injury. This was a 33-year-old male. And there's some pictures of his the progress of his injury further along. So assessment considerations, history. I've banged on about it. We know the questions we have to ask. We know the wound can appear benign, as we've just seen, often underestimated. Again, think about people who are working in that industrial role that might not have the training to set them up for success in detecting these kind of injuries. Very passionate. Lack of pain. So a lot of these injuries in the first 2 to 4 hours have no pain. Why? Because we've got immediate compression of the nerves directly after the injury. So they don't have pain initially until we start to get the swelling and the edema and the lack of movement. Then they're like, oh yeah, something's not right. So again, it's a delay of time. The demographic considerations, we talked about it, and we've talked about reporting culture. People don't want to, especially on the job, report injuries. They get drilled into them to report their injuries, but if people are on a time limit, they're a supervisor, they've got stuff to get done, they don't want the paperwork, they don't want to lose their jobs. There's lots of things that come into play with reporting culture, and the demographics, like I've spoken about. The people that we're dealing with often aren't the best at communicating, and we need to talk to them and get that information out. Do what you have to do to get that information. I think the New South Wales Health Department does have a high pressure injection injury assessment checklist, which is really great. I will put that up on their e-learning actually, if you'd like to access that and have a look. So in the absence of the thorough history-taking injury awareness, we may deem the wound insignificant due to the appearance of lack of symptoms. Imagine we send this guy back to work. Like, oh yeah, it looks all right, come back in 24 hours. Feel a little guilty. All right, our assessment. As a primary provider, you're the first person to see this patient. Of course, we need to look at pain, being mindful there might not be any pain. That's okay, keep assessing. Thorough neurovascular assessment, okay? Range of movement, sensation, cap refill, colour, temperature, pulses, strength, and the extent of the oedema inflammation as a baseline. Why? Because it might progress. So as soon as we get them in there, we're going to be marking on their skin where the extent of the oedema that we can palpate or see visually to make sure that we can compare that over time. Although hopefully they'll be into surgery fairly quickly. And we won't have to be checking about that too much and getting real nervous every time it gets worse. All right, I can't remember who taught me this. Has anyone seen this before? 1 plus 0 equals 0, 1 plus 1 equals 1. Raise your hand if you've seen this before. Oh, I'm so excited to share it with you. Okay, so when you are assessing a limb or anything where there's two of them, if you're assessing one limb, you're not assessing anything. If you assess two limbs, you're assessing one limb. Why? Because you are always comparing one to the other to assess what is a normal variation, right? So all of our neurovascular assessments, we are always assessing both sides, even with an injection injury where it's like clearly evident that the injury is on this side of the body. It doesn't matter. You need to compare it to the other side to have a really good understanding of the variation or the severity of the illness, okay? And I've always remembered that because it's just stuck with me and it makes sense, yeah? Makes sense? Clever, smart, I like it. All right, for those of us in hospital, early X-ray. Now, MRI and CT is generally not required during the initial assessment. MRI or CT is generally done post-operatively. With our bloods, white blood cell count, why? Because we've got inflammation, potentially infection, okay? So we need to determine the severity of the infection. We need immediate surgical referral, and this is another thing that's banged on about in the literature. Do not hesitate and do not delay surgical consult for this patient in the ED, right? Even if you have to pull the surgeon out of their little restroom by the ear and look at it, make them look at it, right? Because most of these patients, over 90%, are going to need surgery intervention, including microvascular review, right? Because we've got potentially vascular compromise. The only injuries that showed less need for surgical intervention is water injection injuries. They're generally treated more conservatively, but we can't assume, especially not before imaging. So you'll see here we've got an image of an X-ray. So an X-ray initially is fine. It's going to show us not only any fractures secondary to the impact from the pressure, but it's also going to show us where the extent of the distribution of fluid has occurred. Then you can see on the second screen here, we can see that the paint's sort of showing up. This is the paint from the initial, the one we saw earlier, the 33-year-old male. This is his imaging. Treatment considerations. Always, as soon as they come in, you're keeping them nil by mouth. Fairly obvious, yeah? Splinting during transport. Why? Because we don't want them moving the joint around and spreading that or increasing the compartment syndrome or the inflammation. Analgesia, obviously. Prophylactic broad-spectrum ABs. Cephalosporin was really commonly used in the data. Tetanus, if indicated. There's a bit of to and fro about corticosteroid use. Some of the data says do it to reduce inflammation. Others are like, there's not enough evidence. I'm going to leave that up to the Lords to come up with in a few years. There is good evidence supporting vacuum therapy. This is post-operatively, right, to reduce the inflammation and swelling there again. Right, early debridement and heavy irrigation plus. Usually, in most of these patients, they're having at least 4 debridements over the span of 2-3 months. So it's a fairly debilitating injury for this patient as well. We need to think about the prognosis in this patient's actual life as well. Their hands, right? You've got to, has anyone broken a wrist before or a hand? Real annoying, yeah? Had to get my husband to tie my hair up for me for ages, right? Ongoing neurovascular observations, physiotherapy and OT. Consider workers' compensation. Ask your patient, where did this happen, right? Because they might need that initial workers' comp. They're probably going to get it. And psychotherapy. Think about the mental health implications related with an injury of this severity and the debilitating nature of the injury as well, not having your hand. It's really, really awful. So we're definitely going to get that in place early. And it needs to be a holistic approach for this person. And the main message you can take home from this as well is education, how important education is. Gnarly, hey? Ugh, been waiting for this. You can see the necrotic tissue there. Now this one's really interesting. See in the bottom left corner, these little bits and pieces? This is the epoxy resin paint. And what happens is after time, it becomes a bit like chewing gum, and then eventually it hardens completely. So the longer that has been in there, they're literally picking off. Anyone ever pulled out chewing gum from a cushion on the couch before? Imagine that. Right, so they're picking out these little shards, and this guy had 7 debridements. All right, avoid compression of the affected area. We've got compartment syndrome. Pretty straightforward. Ice therapy and digital blocks. Why? Because it's going to reduce vascularity that's already compromised and delayed referral, which makes sense. And finally, we need to educate. We need to educate ourselves. We need to educate others. We need to make sure that we are detecting these injuries early so that we can really help prevent poor prognosis and outcome. Like I said, 80% of amputation rates with the solvents. It's really, really debilitating. Thank you for listening today and coming up so early to hear me bang on about this topic that I'm very passionate about. I hope you all learnt something. And do we have any questions? Yes, hello. Pre-hospital, minimal. To be honest, we're not doing much in the pre-hospital setting at all. Rather, you're going to look at your IVABs. If you've got cefalexin, you can get that on board early. But to be honest, we're not doing much at all. We're not going to irrigate, especially in hospital, they'll get like a pressurized, oh dear, pressure, trigger alert, but right, pressurized syringe. So you got your 20 ml syringe with your 18 blunt drawing up to do that. We're not going to do that pre-hospitally at all. It's all after imaging first is most important. The irrigation is going to be happening surgically. But great question, yeah. So literally splinting, soft, analgesic, IVABs, if we can get them on board, or IMABs. Any other questions? Did you learn something? Yay, cool. Thank you for having me, guys. Cheers.
Thanks, Coops, and really appreciate the time that you put into that one and jumping up and starting it off for this morning's session. So, you may have recognised the Mesh logo up there, which is the same as the Mesh that's created our e-learning for us. So thank you very much to Elyse for also putting that together. Round of applause for the e-learning. Some of you may have found with the e-learning link that when you click on it, it does come up saying completed. We have updated the link so that that little glitch isn't there. So if you just go through the info book, the new link is working and active. Otherwise, send us an email. We can shoot the direct link through to yourselves. Coops will be around. So if you do have any questions, want to know more about Mesh, please feel free to come see her. She'll either be here or by the pool with a cocktail in hand, I reckon, is a pretty safe bet. Let's take a real quick couple of minutes, fill up your cups. The plan is we're then going to roll pretty much into the next 3 presentations, almost back to back. So definitely stretch those legs and get excited for the next couple of presentations. Yep, perfect. All right, that one.
So there's a.
So yeah, just what you say, thing too. Fantastic. Thanks.
And then there's the spotlight. Okay. You've got to hold the spotlight on.
We just point. Yeah. Can I pronounce it Tanie? Is it?
Tiny.
Tanie. That's it. I think my head on Tanie.
Ending's very confusing.
Oh really?
I know a guy that every day for the first 5 minutes, 12 months. Be like, morning, Tiny. Hi, Tiny. I'm like, Tiny. So in the end, I end up calling it more Tiny.
Yeah.
Stop calling me Tiny. It's a long sentence right now. It's Tiny.
Right.
Yeah. T-A-R.
Yeah.
Tiny.
All right. I'll look at it.
What? Pick it up and be like, Tiny.
Yeah, I know.
Yeah.
Feel free to use it, right?
It's fine.
All right, everyone. Thank you very much for just making that a nice, quick break there. I don't think I've got anything to say to everyone, so you're in luck. Let's give a nice big round of applause for our next presenters, Tanie and Sam.
Thanks, Quentin, and thanks to Elyse for being flexible and adjusting your schedule. That's very much appreciated. I had a door malfunction, couldn't get into my room, couldn't get dressed, couldn't do anything. So after a bit of mucking around, here we are. So thank you very much. So really looking forward to presenting on our post-nominals, and I'm a fairly lay person, being a firefighter, as was outlined previously, hose fairy. I resemble that remark. I hope to make up for with enthusiasm. My name's Sam Watterson. I'm the Commander of Emergency Medical Services in Fire Rescue Victoria. Any fellow Victorians here? Yep, nice representation, excellent. And alongside me is Tanie Strickland, who's our EMR Program Director at Monash University, who do our training. And Tanie's also a long-serving registered paramedic as well. So we're both very much looking forward to outlining our emergency medical response program that we have in Victoria. Thank you. So who we are, we're a modern fire rescue outfit that serves the people of Victoria. Firefighters respond to a vast array of incidents, hazmat incidents, fires obviously, high-angle rescues, road accident rescues, and of course our emergency medical response role. There's 85 fire stations in the Fire Rescue Victoria agency, and they're represented by 47 in the metro area and 38 regionally. So focusing on the EMR program, it was established after a trial in the late 90s. That trial showed a significant amount of success, so the program was confirmed in 2001. That program sees us co-responded with ambulance to priority or certain priority zero events, and that leverages off our fast response time and strategic locationing. So we do understand that ambulances can be delayed, high caseload and ramp in and all those other sort of modern pressures that we have on our health system. Firefighters tend to have a little more availability, and that sees us respond normally in around 8.5 minutes as a response time. And as we all know, that chain of survival, those first few minutes are really critical to get early CPR, early defibrillation. And we do provide that service right across the state at all 85 stations. The program's unique. It was a world first. While we have models overseas where, particularly in North America, where there's potentially EMTs or paramedics that are on fire trucks, our model sees all firefighters trained to a basic level to provide that advanced first aid, advanced resus and defibrillation capability. So it was a world first model, and it's starting to be picked up in different places around Australia particularly, which is a good thing because it does have a significant impact. So in terms of our call load and case loading, in 2009 we attended around 3,500 EMR incidents. In the 22-23 financial year, around 6,400, and now for this last 12 months, we're in excess of 10,000 EMR calls a year, so significant uplift. The drivers for that, we're all very well aware, being healthcare professionals, not myself, but the people in the room, of course, increasing and ageing population, the post-pandemic impacts, people not getting regular checkups, comorbidities becoming more entrenched, climate impacts, and it's now a really key function of what we do, and it accounts for around 30% of our actual work is emergency medical response. So no longer are we an agency that just goes and puts fires out and pulls cats out of trees. I've only done that like twice in 20 years, mind you. It's such a cliche.
Oh, this is me. So this is where we fit in. So Fire Rescue Victoria like to sit on top of our love triangle and our training love triangle. So I'm from Monash University. We are the current training providers for our firefighter emergency medical response program, and I'm the director of that program and have been for the last 2 years. We sit and work alongside Ambulance Victoria because, as you all know now, our firefighters respond to Ambulance Victoria's Priority Zero cases. So it's really, really important that we have this love triangle established. And I mean, who doesn't love a good love triangle? I always think of Carrie Bradshaw and Mr. Big and Aidan, and also our good friends, Camilla and Charles and Di. And I also have a bit of a joke about the love triangle and probably why Ambulance Victoria and Fire Rescue Victoria have very minimal co-locations now, because we all know the good love triangles that happen at work. So with regards to our training, for our firefighter recruit course, our firefighters undergo 7 days of initial training. So majority of our firefighters come in as from trade backgrounds, paramedics, police officers. We have military personnel and teachers. We have a very wide range of people that come into us. Initially, they are trained to advanced first aid level and advanced resus level. We add in things like remote area access, and we also consult for other courses as well. So our firefighter initial training in that recruit phase is the 7 days. We send them out on station to live their best firefighter life and to be exposed as CPR monkeys, get them exposed to the cardiac arrest, performing CPR, and we get them back for a 4-day retention phase, about 6 to 9 months. We bring them back into the classroom, we go over the cases that they're seeing, and we get them signed off on all of their airway. So currently our firefighters are able to BVM our patients. They have OPAs, but we are looking at an enhancements package, which Sam will talk about after. We have a bespoke course, which is up there, the course in Fire, Rescue, Emergency Medical Response, First Responder, which is their certification. It's looked after by the FRV RTO. And then ongoing training for our firefighters is monthly continuing education sessions where Ambulance Victoria paramedics come out onto station. Hello? Yep. Where our firefighters are trained, and we have themes of the month, really. So leading into summer, we'll look at things like drowning. We were just saying about Cripps' presentation, that would be an amazing CE session for our firefighters, because particularly our hazmat teams and our heavy rescue, they are going to these kinds of injuries.
Try that one.
Oh, Sammy, that's better. I do have a loud voice though, so I'm not sure. It's gone again. Oh no, here we go. Ambulance Victoria support us. We meet with them and the medical directors monthly to ensure that we're all training on the same page. Every 3 years, our firefighters come back into our classrooms amongst our 8 statewide hubs and are recertified in their advanced first aid. Their resuscitation is updated every 12 months. What we do know from looking at our firefighters' caseload is that they're exposed to cardiac arrest quite often. So we would say they work a 4-on 4-off shift like ambulance. They're often going to 1 or 2 cardiac arrests every 4 days as a minimum. And when we look at the average in Ambulance Victoria, the average advanced life support paramedic is probably going to 1 workable arrest every 18 months now. So our firefighters are certainly their hands on our sickest patients. And it's an absolute, from working on road and still working on road, it is a program I value greatly. It is so, I've got the AV paramedics nodding. It absolutely decreases our cognitive overload. It means that we can actually get on to the next stages of care knowing that our firefighters are doing the CPR, that they're able to dump the shocks in when we need them. They are an absolute wonderful support agency for us. We do say to them, hey, we need a chair moved, and it literally looks like the patient's moving out of their home because they'll clear whole rooms. They work out all of the logistics for us, and it's a wonderful team to be part of in this little love triangle. Sam?
So in terms of equipment, fairly basic, but we've upgraded it recently to, reflect the modern type of calls that we're going to. So oxygen resuscitator with suction, nothing too fancy in there. We've got a trauma kit, backpack first aid kit, which we've recently upgraded to carry a significant amount of bleeding control equipment. So Elias dressings, hemostatic gauze, and a number of tourniquets, which is something that we'd identified through some research from one of my great staff members, Station Officer Sam Maletta. If anyone was at TACMed, he presented this recently, so he put a wonderful amount of work into instating that capability. And then defibrillation, so just a basic semi-automatic defibrillator, which is due for replacement, so future project.
Just waiting for Ambulance Victoria to get their tender happening. So
we can't really pick a defib until ambulance pick it. We really need to be compatible. So once they zig, then we'll zag and we'll make that purchase. On our rescue appliances, so appliances that are sent to car accidents, industrial accidents, rope rescue incidents, etc., we carry a advanced sort of trauma kit, and inside each of those is a bleeding control throw kit. So it's a vacuum sealed kit. It's got a QR code. It's intended for other emergency services. At mass casualty incidents, it's intended for anyone in the public. They can scan the code and see how to apply a tourniquet, see how to use the kits, which is really good for those mass casualty incidents where there is that, like Tanie was saying, the cognitive workload is extreme. And when you've got a number of patients and limited people, we need to be able to spread that resource in around. So, and then also a soft lidded drag mat for patient evacuation, which forms part of these kits as well. So that's the equipment that we carry for now. Clinical governance. So another great body of work that our team has done is really revamp our clinical governance. So we are providing this service, and it really needs strong policy around it to make sure that we are doing things clinically correct. We're keeping our people safe, and we're looking for patient outcomes that are based around good policy. So we've got supervision from the Fire Rescue Victoria Chief Medical Officer. We employ a Chief Medical Officer. Clinical practice protocols and clinical skill sheets form that clinical governance, and they're reviewed and authorised by Ambulance Victoria's Medical Advisory Committee, and that gives us that safe and relevant guidance. And then, if there's changes that need to be made, we work with Ambulance and the Medical Advisory Committee to make sure that those changes are reflected in our governance, which is good. So our impact. We have saved hundreds of lives over the journey of this program, hundreds. And it's really difficult to quantify. When I say hundreds, they're the ones we know of. And it is really difficult as a first responder and people who work in that pre-hospital care space when you go out to some of these sickest patients. And sometimes you will never know the outcome. Sometimes you don't want to know the outcome, and that's okay as well. But it is difficult to quantify the impact, but we know it's significant because the ones that we do get made aware of, we have a number of them. So there's a few photos up there. This is just over the last 12 months of a few of the patient reunions we do, which we find really rewarding for our crews to see the impact of their work, knowing that because we only go to arrests are generally not great outcomes. It's an end-of-life event, or there's been a traumatic injury that's put them into arrest, and the outcomes are not great. So when we're talking about a 3 to 5% success rate, and our firefighters are only going to arrests, there's a lot of poor outcomes. So when we do have good outcomes, we like to celebrate it. It's really, really important for us to reinforce that what we do is having an impact and it is important. So these can get quite emotional, these reunion events, and we always share those successes with our AV colleagues who we find just absolutely wonderful. And these types of events tug on the heartstrings, but they're a really important and symbolic reminder to our people about the impact that we have. So for the 100 EMR jobs that you go to where there's a bad outcome, if you have one in there where there's, you've saved someone or potentially not saved them, but prolonged their viability for family to come and say goodbye to them at the hospital later. So that's another way that we sort of think of a reward for the work that we do. So welfare support, it sort of came after the program, unfortunately. And I think in a lot of the industries that we work in and the sectors specifically that we work in, I think it's been the same. We do all this significant work without entirely understanding the traumatic impact on our people. So we've had to evolve it and learn along the way to a point where we now have a very established peer support network. We employ clinical psychologists. We have a significant number of external services that we can refer our people to. And we can leverage modern technology to track trauma and the impacts of trauma on our people. So recently we went from a paper-based PCR, patient care record, to an electronic one. Having an electronic patient care record allows us to track exposure for our people. So I can put someone's pay number in and into this program, and I can see how many arrests they've been to, how many times they've done CPR, whether the outcome was poor or not. And that really gives us an insight into people's welfare. And it gives us an opportunity to, have a flag pop up and maybe tap them on the shoulder and see if they need any extra support. So it's stopping that Swiss cheese effect where people are slipping through the gaps. And having that technology allows us to do that, and a number of other things as well. So the EPCR allows that real-time data sharing with ambulance. Or anything that's inputted into it can be tracked, monitored, challenged, analysed, which helps us identify trends, whether it's, opioid overdose trends or other sorts of incidents, and look for opportunities to improve the program, because we are always on the lookout for finding, avenues to support what we do for AV and the community more broadly. Data is a very, very powerful tool. And one of the recent things, and I just want to highlight one part of our EPCR, which, people might find interesting. We actually have it now where as our people go through, and it's just on a tablet or a phone, as they go through and put the data in for the PCR, it'll automatically generate AI case notes down the bottom. And then you can just review the case notes, make sure they're, reflective of what you've done, make little changes, because AI is not perfect, of course, but it takes a lot of the work out for our people. So, having those automatically generated case notes are good. It's sort of hard to see there, but there's one. So on the left is the inputs. That's how our patient care record looks like when it comes to me or to AV. And then on the right, from all those responses we've put in, and there's a few pages of them, but there's just one, there's a AI-generated summary that outlines the case details, interventions, and any follow-ups that are required for the crews. So, that takes a lot of the pressure off our people, makes our systems more automated, and like I said, gives us data, valuable data, to be able to improve our program over the journey. So, that's a big one I want to show you, and I'm sure it's established in other areas as well, but it's a pretty easy thing to do these days with all the technology, et cetera, that we're moving into. So
just on the EPCRs, for us, that's become a massive thing. Obviously, Monash University, we love our research, our evidence-based practice. So we are currently about to embark on a massive study on EMR over the years, where we've started, where we've come from, the caseloads we're going to, as Sam mentioned, like how many patients are we going to that have had a narcotic overdose, to look at things like having intranasal Narcan and things like that in our program for our first responders. Now, it's really hard to go, hey, we go to these cases without data. We all know that. So we are starting a research project, but I currently have 120,000 handwritten case sheets to grab my data from. So the introduction of the EPCR has my nerdy research hat. Absolutely so excited that we can now just drill in whatever we want and it comes up straight away for us. So that will be a massive change for us. And Sam's done so much work around this. And we're also finding our crew compliance in writing their case notes is so much better. We're getting much better data. The case sheets for fire rescue are aligned through VACA, so the Victorian Cardiac Arrest Registry, with Ambulance Victoria's case sheets. So basically they align the fire rescue case sheet, the Ambulance Victoria case sheet, defib data from both. They all get sent in. They can be used in the coroner if need be, hopefully not, but can be used as evidence and things like that. But the EPCR and PCRs are really, really important for us as well for aligning our patient outcomes. Mass casualty incidences, you either love them or you hate them. I'm an absolute lover of this. There's a few weirdos. It's probably because I'm quite bossy, so I like to oversee these scenes. So mass casualty incidents, it was something that we felt ill prepared for as a service, being Fire Rescue Victoria. So we've made it a massive focus over this year to now that we've got our great first aid equipment, to do and embed mass casualty incident training for our firefighters. So we embed this into the retention phase of recruit training, where the firefighters basically come to us and we have a whole day of mass casualty scenario training, in which I'll show you in a second. So this was our, up on the left there, they were our initial hard Pelican cases of first aid. Pretty much out-of-date bandages, there was sports tape, there's giant yellow bags, there's things that we just don't pull out at all. So now you saw the red backpacks, they've all been modernised and harmonised for the jobs and for the equipment that we actually need to use when we're on our jobs. So we also had no clinical practice protocol or clinical approach to a mass casualty scenario, so we have embedded that in clinical practice protocols as well. And there was no ongoing specific trauma care training for mass casualty incidences and updates on that. So that's a focus for us in all of our training at the moment. Here are some of our mass casualty events in which we've attended. So South Melbourne Bus Crash 2016, the 2016 Springvale Bank fire as a weapon attack. I was one of the Ambulance Victoria acting team managers there that was at that scene. 2017 we had the hostile Burke Street attacks, Flinders Street as well, and then last year we had the really horrific school bus incident where there were a lot of paediatric patients trapped in a bus rollover. So we've looked at these scenes. We've also looked and considered at incidences like the Bondi Junction massacre up there, and really put that focus on our trauma training and trauma kits and how we can do greater good for the greater number of people. So our vision, basically we looked at the data and from worldwide incidences, and we learnt lots from them. Can you just click forward this one? We obviously have introduced the new equipment, we've better trained our people, we've established the clinical governance to support and guide the actions, and we wanted to ensure that we can effectively support Ambulance Victoria as a response unit to these incidences. We know with Burke Street, our firefighters were some of the first people to arrive on scene because the information was really sketchy. We all know at these bigger events, they're widespread often, the information coming through isn't quite what we get told initially. So we looked at overseas, and we looked at things like there was no stretchers available, so the responders had to quickly improvise, as we can see, trying to carry this lady out. Hence the introduction of the soft carry litters. They're used for very quick extrication, can move multiple patients in a really quick fashion. Then we also had that responders had to improvise with tourniquets, stretchers, and more effective ways of managing these patients. We know at Bondi, people were trying to pack wounds with clothing that they had gotten out of a store. Hence why we've designed those black backpacks. They're like a Pez dispenser. You can wear it you dispense and throw the throw kit with the QR code. So you can direct whoever is first responding on that scene, whether it be a first aider, doctor, nurse, paramedic, anybody else in the community, on how to use that equipment if they need to, so you can rapidly move on to the next patient. So our goals with our training was to train our firefighters to do the basics well. We wanted to recognise and apply the protocols to life threats that we can impact on, which is basically our catastrophic hemorrhage. So we've moved that up into our danger response. Severe bleeding comes in there for our firefighters. They know now that at any traumatic case, they need to stop severe bleeding before they move through the primary survey. That includes car accidents, traumatic arrests, and things like that. How do they do that? They now have tourniquets. We did have a crew out in Ballarat, so metropolitan Melbourne, a couple of hours out, who attended a cyclist versus truck sometime last year, and they had no tourniquets on the truck. So they used some Telstra rope out of the truck and a spanner to improvise a tourniquet and save a patient who was peri-arrest. Now we know that that's, yes, they did a wonderful job, but can we make their training better and can we give them better equipment? Yes, we can, hence the introduction of the tourniquets. We also have taught them how to wound pack, so they know how to wound pack. They also use an improvised pelvic bind as well. So obviously when we were selecting our equipment, we needed it to be fit for purpose, to fit in our trucks, which has been a bit of an interesting time, hasn't it, Sam? We have embedded it into ANCTC exercises, so not only with our people in ambulance, our Monash University students, but we are going wider. So we're working with the military, we work with the police, the CERT teams, to embed our training into these greater exercises, and also within FRV. So USAR, ropes rescue, heavy rescue, we all work together. And yeah, obviously, because we wanted it to be interoperable. Do you want to talk about that, or do you want me to?
Yeah, I can talk about the guidance. So yeah, we spoke briefly before about our update to our clinical practice protocols. We call them protocols. We don't call them guidelines like many other health agencies, because we want our people to strictly follow those protocols. So clear instructions and actions prior to AV arrival at mass casualty incidents. So we really wanted to focus on LSIs, addressing that preventable cause of death, greatest amount of good for the greatest amount of people, using those principles to drive the policy to make sure that we have now that clinical governance to be able to support our people when they're attending the mass casualty incidents. And our specialist counterterrorism personnel, we have a counterterrorism department, but we've also got Sam in our department who's trained in counterterrorism, and he's used that experience to embed our processes and policies with these new CPPs.
So how have we gone about training such a large workforce? In order for us to be able to roll out new equipment, we have to meet 80% training. So we've done that by working with Ambulance Victoria in clinical education sessions, and also doing our updated skills acquisition program. So having our firefighters come in and train with us in the 8 statewide hubs. So one of the major concepts that we introduced that we felt wasn't being done particularly well, and it's certainly not done particularly well, putting my ambulance hat on, is introducing, and no, we certainly don't break down the lethal triad right down into its real deep patho, but we just want our firefighters to be aware of the lethal triad, that we need to control hemorrhage, we need to do better at keeping our trauma patients warm because our cold trauma patients die. And, we've taught them better utilisation of thermal blankets, and also just how to set up casualty clearing posts and things like that. We don't expect our firefighters to be able to tag, sort and triage, that's way too hard when you're in turnout gear. These guys often go into hot zones that we're not in, and we're waiting for our patients to be brought out. So we had to sort of look at a way that we can get our firefighters to triage. We have based a lot of our triaging on Dr. Claire Park's 10-second triage, which the UK use, UK-wide now, which is a really wonderful triage program. It requires no hands-on obs to be taken. So we utilise those concepts for our firefighters so they can identify catastrophic hemorrhage, patients who need some airway management before you move on. And it's been a really nice simplified form for the firefighters to work out who's really sick and who we need to prioritise. And we've embedded that into our mass casualty scenario training, which you'll see in a sec. So when I first came into the department, we had a really cute tabletop exercise, which was literally little matchbox cars and Lego men. And that was the scenarios we'd use to emergo train and, like, you know, drive people around and go, that one needs to go that side. And I went, well, we've got these amazing facilities at Fire Rescue Victoria. We have props like trains, trams, cruise ships, buses that are on their sides, things like that. So how about we use the props and we scrap the tabletop activities? So we actually now work with our practical scenarios. We've introduced external role players. It's a wonderful opportunity for our undergraduate paramedic students to get involved with our program at FRV. So we have our undergraduate students come in, they role play, we get them all moulaged up, they become ambulance crews, we basically embed them into our training, and Monash have really embraced this, and our students are absolutely wonderful. We also have people from the community that come in and help us. You'll see in the video that we're about to play that we have a man who is a real life amputee. He wants to give back to a service that gave him so much in his life, and so he comes in as a volunteer for us to be able to create that realism for our crews. And they certainly don't expect to find a patient that actually is missing a leg. So this is one of the mass casualty scenario drills that we ran in June earlier this year. So ignore the cheesy music that production gave to us. But this is our mass casualty training drill. Basically, the scenario is a wayward teenager's driven through a bit of a festival, and that wayward teenager belongs to me. So one of the concepts we've introduced to them with our casualty collecting posts at these bigger scenarios is that we're at these scenes, we are absolutely equipment deprived, yeah? We're sharing, we're running around stuff. So we've taught the firefighters to place our patients either in a circle and have firefighters there that can utilise gear, or to place them head to head with a line through the middle out near at the casualty clearing post, so that then they can manage multiple patients at the same time. As you can see, we do try and do our best with our moulaging and getting the students involved, and that was just sort of a short snippet. Yeah, beautiful, but it is a great opportunity.
It was the particular day that we did this, we didn't warn the facility that we're doing it, and we had people running out thinking there was some significant event happening, such as the good acting of the Monash paramedic students who came, and we're very thankful for them to do that. And it really does, it takes away that mundane training environment where our people sort of mosey on in, and they walked on in, and even though it's training, they were sort of overwhelmed, and you could see that they kicked into gear a bit better. And if we try and train how we like to apply our skills in the field, then you're going to be better for it, and it's going to have better patient outcomes.
Yeah, absolutely. And I guess we've got to consider as well, we can probably skip that slide. We've got to consider as well, they're our recruit firefighters. They've only been out on station 6 to 9 months. So, they're the ones that will probably be in the calendar in the next 12 or so months.
So there's the trauma kit that we were talking about before, just a really handy bit of kit, purpose built for mass casualty incidents where we can have that great impact by using people around us to support us. So where to from here? So we don't want to sit in our heels and just let the program sit. We're 25 years on. It's a quarter of a century of doing this program, and we need to continue to be agile and adapt and look for opportunities. So we're working with our partner agencies, Ambulance Victoria, 000 Vic, to look at additional Priority Zero coding, particularly now that we have that enhanced skill set around mass casualty and trauma. So there's a number of opportunities there that we can pursue. Introducing SPO2, SPCO, particularly the CO one, it's really important for our own capability and self-sufficiency at incidents. So post-fire monitoring to make sure that our own people or public, we're monitoring for that carbon monoxide exposure, and then referring to ambulance for treatment, and then potentially hospital for further treatment. LMAs, the airways have advanced significantly over the years, and while OPs have been a bit of a workhorse for us, there's better ways to do it. And we're using LMAs. It's an easy transition when ambulance arrive on scene. It's a harmonised bit of equipment. Next generation defibs, the backpack first aid that we showed you. We're looking at a suite of pharmaceuticals, just basic first aid pharmaceuticals, including naloxone. We all are aware of the opioid problems that we have in communities, and what's going on in North America that's eventually going to hit our shores. I had a roundtable meeting with the Lord Mayor in Melbourne not long ago, and they're going to start putting intranasal naloxone in defib cabinets that they have around the city. They're looking at giving it to their parking officers, these people who are at the front scene, front facing to the community, where you can have a quick impact. It's a life-saving medication, very easy to use, very safe. So having our people as first responders equipped with nasal naloxones will be a really important step. Salbutamol, another easy one where we can have an impact. Those of you from Victoria would have remembered the thunderstorm asthma issue that we had a few years ago, where we lost a number of people, and in some ways needlessly, because we just didn't have bulk supplies of salbutamol. So we do have cases of it around the state now as a health response, but issuing it to our firefighters, another critical way of getting medication to people when needed the most. And then, of course, auto-ejector adrenaline, so EpiPens for those anaphylactic cases. So modernising what we do to make the impact of what we do greater for the community.
Thanks.
So, look, thanks for the opportunity to present today. We really appreciate the invitation from EMS Conferences Australia. I think these things are wonderful. I really do. It's a great way to network. We'll all learn things. I mean, I'm a lay person. I'm not a medically trained person, but I've seen a hydraulic injury, and it was really good to have a better understanding about that. And we'll probably have a chat to you later about including a bit of that in our training to make our people aware of it, particularly since we're an at-risk cohort. So, thanks for the opportunity to present. We're very grateful, and we're looking forward to continuing to socialise and network and with everyone. And thank you very much.
No, and a huge thanks to you both. Really appreciate you both coming out and putting on this amazing presentation, which we're very jealous of, especially in WA, where I think we joke that we're years behind. I think potentially decades behind here. So, let's hear it again, guys. Thank you.
That's okay. As Ambos, we don't have the fancy dressings in Victoria either, so don't worry, we're jealous.
So as promised, we are going to roll straight on to the next presentation. Please don't be shy though if you do need to stretch the legs, grab another coffee or anything like that. So please make... I think we're ready. Yep, we're ready. Awesome. Our next presenter, Dr. Elizabeth Elder, welcome and come on up the stage. Cheers.
I don't have a clicker. What's the matter? All right, good morning, everybody. My name, well, people call me Dr. Elizabeth Elder, and some days I still don't believe I've got a PhD. I'm a registered nurse, so a little bit about me. I've been a registered nurse for over 20 years. I live in Queensland, so Gold Coast. That photo is actually from the ED I grew up in, so that's where I started as a new grad, and I've sort of stayed associated with the health service in some way, shape or form. I still work clinically, so Monday to Friday I sit between the university and the health service as a researcher. I look at workforce research. So I look at stress, coping, demoralisation and how we can keep people like you and me happy and healthy and not leaving the workforce. Saturday, Sunday, because I don't have a life, I like to work in the ED across the road in a nice little private ED. It's really busy. If we see 50 patients, we've been smashed. So, you know, I might triage 10 people in a 12-hour shift, but we don't have a big workforce. We have maybe 4 nurses on shift, so it's a little bit different. How I came into this workforce research was about 8-9 years ago when I finished my master's degree. I looked around the room and I noticed I'd lost the twinkle in my eye. I used to love coming to work. I was so excited to be an emergency nurse. The adrenaline would rush and then I'd get to work and it's like, oh dear God, it's just another day in the department. And when I did that, I looked around and I saw everybody else was feeling the same, and we were losing really high quality staff, doctors and nurses. People who I really looked up to and who taught me how to be a nurse, an emergency nurse, they were all sort of just dropping like flies. I mean, there's always natural attrition. People leave, people go on to other areas, but really great clinicians were leaving. And I thought, how can we stop this? The only way to stop something is to actually understand the problem. So I don't recommend it to everybody, but I embarked on a PhD in the area of stress and coping so I could work out how to improve our work environments. I don't need to give you the statistics because this is what we all live and breathe every day. We've had an increased demand for ED services globally. It doesn't matter which country I sit in, doesn't matter who I talk to. We know that in every country, the demand for emergency services is increasing. There's lots of reasons why. It's very multifactorial. In Australia, it's around, you know, the inability to access a GP. We've got growing demand in terms of, you know, more chronic illness. Lots of reasons why. And it doesn't matter what we do. We build new departments, we build new hospitals, we expand, we try and recruit into the health workforce. There's always a mismatch between people coming through the door and what we can provide. So the demand on us is increasing. We know that the number of presentations has increased by 1.6 million or something in the last decade or so. And we've got a predicted shortfall. In the next few years, we're going to have about 100,000 short nurses, about 2,000, not quite 3,000 shortage of doctors. What concerns me, it's not emergency per se, but about 25% of GPs intend to retire in the next 5 years. If we already struggle to access a GP in the community now, where do these people go? They're going to get sicker, they're going to present to ED. So if 25% of GPs intend to retire in the next 5 years and only 13% of med students elect that as a specialty, I think we're only going to get busier. Our job's going to get harder, we're going to see more people, we're going to have this constant flow. And we don't have the bucket of money. I'd like a bucket of money like this to solve the problem, but we just don't have it. So my research overview, a little bit of what I've done. I've been involved in some cross-sectional studies. There's, you know, some surveys between Australia and Sweden. So some of the work I'll present today is part of the broader team. So some of that's part of my PhD, the WES study, and some of it's actually the de-stress study. So you might get those annoying emails from me via ASIM or CINA, or I might snowball them, or friends might forward them on. So I'm currently running a longitudinal national study. So I'm trying to now track and trend what the differences is and see how we're shifting and changing in our stresses. I have talked to a lot of clinicians. Surveys are great, and I love statistics, and don't tell my statistician that because I usually walk out crying and pale when I have a chat to him. But, you know, I think to understand the stats, I have to actually interview people. I have to sit down and talk. Like if you're talking about workload, like what does workload mean when I actually sit down and, you know, look at those numbers? So I've spent a lot of time interviewing people. I've done nominal group techniques. So I've brought clinicians into a room and I said, okay, these are the problems you're telling me about. which one do we need to address first and what are the solutions? Let's make this end user savvy. Let's make it the people who are actually receiving the interventions we develop. I'll need them involved, because there's nothing worse than a cherry-picked intervention or a management coming down saying, hey, we've noticed you've got this problem and this is what we're going to tell you to do about it, because it doesn't actually address the concerns we have as clinicians. So some of my work, like I said, has been from Grace Yu's work. We've got Louisa Abrahams, currently working with Monash as well. We've got a few other partners around the world. And some of my work, the de-stress study, is currently being translated into Danish, and we're going to pilot it in Danish soon. And then we're going Swedish, Dutch, and maybe even French as well. So we're hoping to take this global. So in a couple of years' time, I can come back and say, it's not just us, this is what we look like around the world. So part of what I did was I gave out a survey. Well, I gave out several surveys, and I keep handing out surveys. Now it's online, but during my PhD, I actually physically handed out paper-based surveys with a Freddo frog attached, because everyone knows in ED, if you come with chocolate, you're usually liked. So we have a list of scales. So it says, out of this list of things, can you please rate on a stressor scale? So the more historical work was on a 1 to 15 scale, the more recent work. So in Ellie's work in the single site study, she did with her masters with us, we changed it down to 1 to 7, and that just made it a little bit easier. And we asked staff how stressed they found, these sort of items. So inability to provide optimal care. It doesn't matter where we ask that around the world. So Sweden, Southeast Queensland, my national study, that's one of the more stressful things. So out of a 1 to 7 scale, consistently we're scoring quite high. So, 6 out of 7. I don't have the IQRs for the national, because we've done some standard deviation type stuff. We've done a slightly different statistical analysis, but the mean scores are still the same. Heavy workload and poor skill mix. Poor skill mix is interesting. When I talk to clinicians, I often say nobody wants to work a Monday late, because that's when the departments are really busy, and that's usually when we have a lot of sick leave. So in comes a casual pool staff or the locum staff. So skill mix is an interesting one. And we're also noticing now too that with the high turnover of nursing staff, and we've got about a 3 or 4 year average turnover now of registered nurses in ED. They don't seem to last too long, that we're very junior heavy. So that adds a lot of pressure to the more senior clinicians. Overcrowding's a big one. Workplace violence is one. I do notice that's normalised a little bit now. It's like just part of the job. People just expect to be spoken to poorly or to be, threatened with assault or actually assaulted in the workplace. And that is really concerning that we've normalised it. Death or sexual abuse of a patient. This is one that is very stressful, particularly of a child. But fortunately, when I actually sat down and asked them how often they're exposed to the sexual abuse or death of a child, it was probably one of the rarest ones they were seeing. So even though it's one of the most stressful, it's actually thankfully something they don't have to deal with too much. High acuity patients, and then infectious disease exposure. I just want to preface this one here, the infectious disease exposure, for the national study and for Ellie's work in the single site study in Southeast Queensland. Ellie actually did it during COVID, and the national one is post-COVID. If you see the pre-COVID data, it was something that they said they never saw and they didn't find it overly stressful. So that was, an interesting shift in life. A little bit more historically, so remembering that these were 1 to 15, not 1 to 7, you can see that there's not much change. So it doesn't matter from 2017 onwards, 2016, 2017, to now, we're pretty consistent with how stressed we are and the kind of stresses we're finding stressful in our workplace. So I did ask them how often they're exposed. So this is from Southeast Queensland, 2 study sites, 1 health service. And they were sort of saying on, this is a weekly, we called it, a regular, so weekly, at least weekly, they were exposed to things. Heavy workload, it was almost daily when I spoke to them. A lot of them were saying this is a daily occurrence. It's not something that we have much of a break from. Environmental concerns, it was another thing they saw very frequently. So 81% of people, or 77% if you add them together, are seeing it daily or quite frequently. High acuity patients, 98% of the time. Everybody was saying, we see this all the time. Medical legal concerns and, dealing with media. The media one doesn't surprise me, given the fact that there's usually dedicated and specialised people within departments or health services who are trained to speak to media. So if you were asking me, that's something I never do. So I would, rank that down to a rarely. So that one didn't surprise me. The death and sexual abuse of a child or a patient, like I said, the child one, it's something they don't see that often, which is, actually something I think is a good thing. And when it is the sexual abuse, quite often we then, there's dedicated people again who are, tasked with looking after those patients. So this is the interesting and exciting stuff. This is the first wave of the national study. So the national study has 4 time points. We've now collected times 1, 2 and 3. And so hopefully in the next few months, you'll all get an email to say, if you're interested, please complete the last of the national study. We are about to replicate it and do it in depth in Queensland as well at 6 study sites. So if you're in Queensland, and you might be lucky to be one of our study sites as well. Don't worry too much about the numbers. The numbers are fun stat stuff we do. Look at the lines and the thickness of the lines. So blue lines means good, red line means bad. The thinner the lines, weaker the association, the thicker lines, the stronger the association. So we looked at work engagement on demand. So how engaged, how much are you giving to your workplace? And so we know when burnout is high, so when the staff are reporting high levels on the burnout scales, their work engagement decreased significantly. So they see the really thick red line. So we know that's a bad thing. So strain as well, when their strain was high, so that's when their mood is low, when they're reporting, to have that sort of low self-esteem, they're exhausted. That also became a really big predictor of decreased work engagement. And that's concerning because if I come into work either burnt out, high levels of strain, or even a bit of emotional dissonance, my engagement drops. So what happens to the nurse and the doctor standing beside me? They have to work harder. So then it sort of has this cascade effect, right? That it's just going to continue, a bit like cancer, it starts here, get one bad apple and it continues on. Things that were more likely to help improve, so when their stresses were low, their burnout was low. So if you can reduce the exposure to stresses, or we can help to maybe come up with some coping strategies to address those stresses, then their burnout is low. When their burnout is low, or their strain is low, those two are highly correlated as well. So it's important to look at which ones we can work together with. Demands on intention to leave. This is a really important one. Like I said, with the GPs wanting to leave or set to retire, doctors and nurses are wanting to leave in droves. One of the questions I ask in my survey is, do you intend to leave the emergency profession in the next 12 months? And any idea what numbers I'm getting? 50%. 50% of doctors and nurses would love to leave in the next 12 months, and that's from emergency staff only. That's really scary. Now, ability to leave and intention to leave are 2 different things. I have a mortgage and 3 children, so my ability to leave is really limited, but my intention to leave could be quite high. So we haven't measured actually ability, but they intend to leave. So demands and intention to leave. So what we can see here is that when they have high burnout, they're likely to leave. Again, go for thick lines. Thin lines, less stronger. The thicker the line, the stronger the association. So when their burnout is high, they intend to leave. When their strain is high, they intend to leave. Yep, so that's how we can look at this. They were all shown to be statistically significant, the thicker lines, so that was the other thing. So we could tell that when we looked at this, that this was actually of concern. I'm actually really worried if 50% walk out the door because we don't have enough staff. I know our roster in the public ED where I work, on any given day, we're probably 10 or 15 people short before the day starts. So if 50% of the existing body want to leave, that's really, really huge. And then we end up with, more junior staff, more casual people coming in, and that just adds to that strain. Resources and intention to leave. So again, when we ask them, so what are some of the things that might make you leave? And on the survey, we know that executive management was a big one. When they don't feel supported by executive management or their perceptions around exec are not good, it really increases our intention to leave. Again, supervisor support, so not so far up, but that immediate supervisor in the emergency department, when that support doesn't seem too good, that's another big predictor of people wanting to leave. Collegiate support was a little bit, so those that, same level kind of support. When that was not so good, that was one predictor. And job control, how much autonomy do you have over what you do in your everyday job was another predictor. It had a strong one. Recovery experiences, that talks about, what do you do after work? How do you overcome that stressor? Is it that you're going out to the pub after work? Have you got good mates to chat to? Are you doing some yoga? How do you actually recover from the stresses at work? And it is a little bit associated, but it's more around support from the food chain and up. Coping. So in the survey, we give a list of coping strategies and we ask them how they're coping. We ask them how often they're coping or how much they cope or how often they use that particular strategy, And, I'd like to actually sit down in the survey and somehow work out if it's effective, but I tend to do that when I chat to them through the interviews because we can sort of delve down in a nice, deeper way. So to help you understand, symptom reduction is actually doing things to actually make those feelings of stress and coping go away. Change situation is actually what can I do to change that situation. So for this incident or the next time, what it is around workload, or is it around, violence that I might be actually able to do myself to fix that one. Accommodation is obviously just thinking, well, okay, so this is what it is. So much more I can do about it. And active avoidance, that's really just saying, I'm just not going to think about it, or I'm actually just next time going to call in sick when I know it's going to be a huge day. So these are different kinds of strategies that we come up with. Debriefing was another one that sort of falls into the symptom reduction as well. And debriefing seems to be quite a positive strategy, but you do need to have people who are qualified in debriefing. If you don't have a qualified debriefer, you can tend to do a little bit more damage than good. So it's important that, we have training as debriefers if that's the role you're going to take. So we do know that avoidance seems to be really associated with symptom reduction. So if you actually can avoid that stressor altogether, that works as a great symptom reduction for you. A few things that we do know that avoidance was a little bit associated. It's probably the most strongly associated one with intention to leave. But that's, I guess, a good way of saying, well, if I just quit my job, then I'm not going to have those occupational stresses anymore. So it's intention to leave, and coping is an interesting one to look at. After I did a lot of surveying, I actually sat down and spoke to people, and this is the bit I really like to talk about, because when we read a lot of literature, and we often colloquially say to people, oh, you're just burnt out. You're burnt out. Oh, I've got 10 minutes to go and I've got about 4 hours of lecturing to do. So I sit down and say, I don't know if we're all burnt out. I really don't believe burnout. I believe burnout is an issue, but I don't believe every clinician I speak to is burnt out. I believe we actually suffer from demoralisation. And demoralisation is very different to burnout. So burnout is sort of like your cup is empty, you're broken, like you've got nothing left to give. It's been like, you're, I guess, the one with the issue. Whereas demoralisation is where the organisation, the processes and structures around you make you feel like you're burnt out. So I always challenge people and say, if you can give the right amount of support, give me the resources, I have a decent workload, then I will cope okay. I'm not going to be burnt out or demoralised at the end of my shift. But as soon as I have 2 or more of these, I'm likely to feel demoralised in my workplace. So it is around the feeling of despair, hopelessness, incompetence, and it relates to those threats and the loss of personal values. And it's usually brought on by the organisational factors. So I think I'm really cognizant now when I talk to people about changing the language, and they say, oh, so-and-so's burnt out. I said, oh, are they? Have you actually measured that, or are they demoralised? If they actually had a decent workload and there was a thermometer and an ECG machine and someone hadn't stole the bladder scanner and they could do their job, would they feel the same? Because as nurses, and I know as doctors going, why hasn't this been done? It's like, well, I don't have the equipment. We kind of have this environment where there's all this pressure. Patients also take some responsibility, so that sort of mismatch between society and organisational and self expectations is patients come in, for whatever reason the GP told them they need to have their appendix out in the next 45 minutes, and you're barely only going to triage them by that point. So their expectation versus what we can do versus that 4-hour rule, why have you got 15 ambulances ramped? Why are these patients not moved to an inpatient bed? So there's that mismatch between what everybody wants and expects. So that's also a kind of part of the demoralisation. We need to come up with that sort of, I guess, common ground around what we can do and our expectations of the services we provide. When I spoke to people, to a lot of clinicians about this sort of stuff, we hear things like it's relentless. There's just no break. And when I started nursing a little while ago, I remember being on night shift and actually having downtime. Like you go, oh, wow, there's a whole area of no patients, and you could sit down and eat. You talk to staff now who do night shifts and they don't get that. It's from the moment they start to the moment they finish, they're lucky to go to the bathroom. You try and take a break. And, people around you go, hurry up and come back because I've got so many patients and, we've got an arrest coming in. So they're not getting that break anymore. Around the lack of support, the questions no before the answer, the answer's no before the question's asked. So, further up the food chain, and that goes back to that executive support, people are saying, that's it, no, the door's closed. So they're not feeling that level of support. Inadequate resourcing, you want to be, no one wants to work a Monday, like I said. I think now that you even go back, nobody wants to work any day because there's not enough staff anytime. And then, one nurse talked to me about how they run out of syringes on night shift on the weekends. And if it was only because she was able to go upstairs and borrow or steal from the peds or the neonatal ward, were they able to give medications at times? And that to me is quite demoralising, that if I can't give medication to a neonate that's come in who's unwell, that's, really quite concerning. I sat with clinicians and I said, okay, so these are all your problems. I can't fix them all, let's fix one. And so they chose workload, and they said, we actually can't fix workload. But what we can do is we can look at ways that we can actually feel better about what we do. So I call it the magic spot in the middle. If you can get to that sort of grey section where you've got the psychological safety and that team synergy, so you can speak up if you're not having a good day and if things are, stressful, or, you're concerned about safety for yourself or your patients, and you need to have that team synergy, so that connection together, then you're hopefully going to get those shared values and feel less demoralised and less stressed at work. They want increased team support, both individually and that wider team. They would like to have, some professional development. They want to see things like that. And they also want to be able to have appropriate social connection. That's one thing I've noticed, is that departments have grown in such a rapid way that initially they were quite small. When you talk to people from smaller departments, they actually know each other really well. If you work in our department, we have 450 nurses alone. So I often walk in the department and I haven't met any of these people before. It's like, oh, wow, who are you? How long have you been here? And they go, I've been here 2 years, because the numbers are so big. Like 450 people is almost like a small hospital. So when you don't have that connection with people, it makes it really challenging to have, a better work environment. Some of the solutions they gave me, they want Fat Fridays, bring food in and everyone sit down and have lunch when they can. No education in service time. Let's go at the back. Someone suggested rugby, and I didn't think that was a really good idea, because we might have more injuries than we actually have good. But so sometimes just doing activities together to bring that team. I did like the Wristman in Reverse app. So that was, someone suggested, why always get told you've not done a good enough job? Why not say, hey, that is so cool, so-and-so detected a ruptured ectopic in the waiting room and saved a life. So rather than saying all the bad stuff, let's actually applaud and pat people on the back publicly and say, you did a really good job in that way. Social activities, someone wants a Christmas party every month because it's like letting go pressure steamer off, and I've been to some of the Christmas parties, so I don't know if that would be a good idea. Group psychology sessions, and they wanted that hospital-wide. So they said, this is not an ED problem, this is a health service-wide problem. Yoga and code debrief. So that's actually whenever you have anything bad, we have a code team for resusces, let's have a code team for debriefing. So you have a specialised team who come to the department, or across the hospital, they're deployed, and they can actually sit and work through some of the issues that the staff have just been exposed to. Where to from here? Well, lots of things are going on. I'm still researching in the space. So if you're interested in doing research, please come and have a chat to me. I haven't done any work in the pre-hospital space. I'd be really keen to talk to paramedics who are interested in doing some research in this area. There's some legislation change. Queensland's now brought in psychological safety as a legal requirement. So we must have psychologically safe work environments. I'm yet to see that tested. Let's see how that pans out. It's only very new. We need to work collectively as a group. When people come down and tell us to do things, they don't understand the day-to-day stresses that we have. So don't leave this up to exec. We need to be a group together and speak up and say, these are our problems, these are the solutions we think are going to work for us. And, try and lobby where we can. It's okay to have a bad day. One of my participants called it sit in the shit friend, and apologised for the language, but she said, we need to have someone who go, you know what, you're right, that was a really bad resus, and I'd feel really bad after it too. It's okay to feel like this. And then move on. So actually having people understand where you come from. Gold Coast has the one department. They do a little bit of mindfulness before, the one ED. They do some mindfulness before they start work. Staff do like mindfulness, but you can't kind of do it mid-resus. You're kind of in a resus. Everyone give me 5, I just need to do my box breathing. It's not going to work necessarily, but it might work for some. So you need to find the strategies that work for you as an individual, but then look at a wider team strategy as well. I'm still doing de-stress. Like I said, if you're interested, please email me. And I'm more than happy to chat to you about research, and we could look at doing something in your local department if that's what you wanted. So we know they're busy places. I can't fix that. I can't change that. I'd like to, but if we could, we need to address the reduction or people's intention to leave in the near future. And that's my contact details if you're interested.
Thank you very much, Liz. Before you run off, we've probably got time for one question, if anyone does have a question in the group. Or no? Oh, no one's feeling brave enough. So if you are a paramedic and looking to do some research, please link up with Liz. I'm sure she'll be happy to chat to anyone after the session as well. So let's hear it one more time for Liz. So what we'll do is just take a quick stretch. Let's reconvene back in 2 minutes and give away some prizes before we go on to our last session. So just 1 or 2 minutes, stretch the legs, shake it out, and we'll get started very, very shortly.
Oh, nice choice in music. I am. I'm ready for it.
Yeah.
Yeah.
We're doing all right with Tanie.
You're right, I smashed it out.
Right, cool, yeah.
Well, because the lovely, what was her name again? Elizabeth, she did some of it, so I'll just quickly. Yeah.
You can only shake chicken every day, though. That's like better on the same day. If your account isn't on public, feel free to email the photos directly onto us and we can always throw them up on the screen. Very, very serious and objective judging criteria. It's the loudest cheer gets the prize. So if you like what you're seeing, let's hear some big cheering. If you don't like what you're seeing or you think there's better out there, just polite little golf claps will do. So if we can throw the first one up, what do you reckon? Aww. There we go. That was polite golf claps. Thanks, guys. All right, next one. Feeding time, I think, at Bali Zoo there. There we go, from the opening party.
Nice.
It's a very polite crowd today. La Favela for anyone who's already been there. One person like that, thank you. Another one from the opening party. Well, we haven't got any standouts yet. There we go, getting around. Oh, yeah, so far we've got a winner. We'll have 2 winners today as well. Oh, down the island of Lucinabongan, I think it's pronounced. From the hospital tour yesterday.
Oh, nice.
Yeah. And our final one, which is one of our future presenters for tomorrow. Oh, there we go. We got a clear winner. I like it. So thanks, Mel, for sending that one through. So Mel, and I reckon that one was the next loudest. No, that one wasn't. Sorry. Yeah, that one. No. I'll get there. That one. There we go. We got there. All right. That's our second winner. Sorry for the suspense there, clicking through the other ones. Please, today's the day to get those photos in. We do it every conference. It's my favourite day. It's Prize Bonanza Day tomorrow. So I think we've got 4 to give away. As a heads up, lots of photos come in on Thursday afternoon, which is a little bit too late to go in, which means that we're heavily stacked for the Friday. So today is the day to get those shots in. Group photos usually do really well, and maybe doing something a little bit crazy also usually gets the attention of the crowd. So we're doing good for timing. Thank you all for buckling in, and with the fast pace of kind of swapping and changing as we go. We are very mindful though that we do have those day trip books and we don't want anyone late to those buses. So for our final presentation today, let's give a nice big warm welcome to Emma, who's going to be talking about changing the culture of healthcare. Let's hear it for Emma.
Hi guys, welcome to Bali. Okay. So my passion, first of all, is to change the culture in healthcare. I'm a nurse in Busselton. In the southwest. Those of you that are elsewhere, it's southwest of Australia. The best beaches, I reckon. But anyway. A bit about me. So as I said, I work in Busselton. I'm actually a community nurse. Sorry, I'm a bit nervous. Also, I've been around, to be honest with you. I've been to Africa, did a bit of volunteering over there, which was incredible. I'm now a clinical facilitator for ECU. I've been doing that for about, probably 15 years. So I'm used to talking to undergraduates. So I'm not used to talking to such a big crowd, to be honest with you. So I'm quite excited to be here and sharing my passion. The 2 photos that I've got up, one is of one of the beaches on the coast, so near Dunsborough. If anyone knows Dunsborough, don't hold that against me. And Marin, I don't know if anyone knows, it's a freshwater crayfish and it's absolutely divine, but it's only available, or you can illegally do it, but I'm not mentioning that to anyone. But they're 2 Marin that good friends of mine usually get. And obviously wine from the Margaret River region. So I just want to know, how many are from WA? Oh, cool. Awesome. And what about South Australia? Yeah, fantastic. Northern Territory? No. Oh, yes. Fantastic. And Queensland? Woohoo, nice state. Actually, Australia's awesome. Tassie? So I was in Tassie for 3 years. I worked there. Pretty incredible. Victoria, there's a few of you, yep. And the ACT? No. Anyone overseas? Oh, fantastic. Welcome. Oh, sorry, New South Wales. Thank you. Sorry, apologies. So basically, sorry guys. So basically today, lovely Elizabeth mentioned before about demoralisation and burnout and all that, and I'm just going to briefly touch on it because I know we've got more important things to do like go snorkeling and drink cocktails and stuff. So basically, what is moral injury and what is compassion fatigue? I don't know if you've heard about them, but I'm going to tell you about them. The definition of nurse burnout, statistics and how can we prevent it. Now, I do apologise because I am a nurse. Not that I'm apologising for being a nurse, I'm apologising on the fact that I'm very aware that there are doctors and paramedics here as well. The impact of burnout on the organisations. Bullying, what is it? We all know what it is, but I'm just going to tell you what it is basically. The behaviours, the statistics, and why does it happen, and what can we do about it. The difference between human values, morals, and ethics. We're going back to our uni days probably, if you remember doing that at uni. What is culture and what is culture safety? And the ideal work culture and the ideal working team. So it's a bit of a lengthy one, but moral injury refers to injury to an individual's moral conscience resulting from an act of perceived moral transgression which produces profound emotional guilt and shame. And in some cases also a sense of betrayal, anger and profound moral disorientation. So it's against your own morals basically. It can be subjective, so it's not for everyone, and not everyone experiences the same. It's the mental, emotional and spiritual distress people feel after failing to prevent or bearing witness to acts that transgress deeply held moral beliefs and expectations. So it basically goes against your morals, however that's why you feel that way. It's being unable to provide high quality care and healing in the context of healthcare. And compassion fatigue, which is my favourite one. You know, we as caregivers and health givers, we give so much of ourselves. And sometimes, and especially if you're an empath like myself, you give and you give and you give and sometimes you've just got nothing to give. I'm sure we've all been in the same position. We've got home from work, we're sitting on the couch and the kids are at us and the husband's at us and the pets are at us. And all we want is 5 minutes to ourselves. So basically it can be described as a state of significant depletion or exhaustion of the nurse's stores of compassion resulting from repeated activation over time of empathic and sympathetic responses to pain and distress in patients and loved ones. So this doesn't only go against how we feel, this is the impact that we have on our patients as well. Because when you're giving and you're giving and you're giving, it's exhausting. And then when you've got nothing to give, you do feel bad for the patient, but sometimes you just don't give a shit because you're tired. I don't like being in that situation, but I've been in that situation. So recognising the signs. Now these are quite vague signs, but I think we can all relate to these at one point of our time. There's depression, anxiety, exhaustion, hence why we're all here probably. Absence of energy and apathy, so no pleasure in activities that were once pleasurable. Insomnia, I think we can all suffer that because we're shift workers. Repetitive nightmares, poor self-esteem and irritability. So our coping behaviours, which we could probably all relate with this as well, is that who gets up every morning and has a coffee to get us going and get us amped and get us ready for work? And then who will come home from work and pour a glass of wine, or who has temazepam to help them sleep? I mean, back in the day when I was nursing, I remember we were just able to get temazepam out of the drawers and take it home with us. Not that I did, but I knew nurses that did, and it helped them sleep. That was their coping mechanism. Overeating. Hello, I'm not the size that I am because I just love to eat. Not that I overeat. Overspending and gambling. So these are all things that we need to be aware of. And first of all, burnout is a really interesting one. So burnout has been around for a very, very long time. And, you know, all the studies that I've read about have all been about COVID and how COVID's affected us. Yes, it has, and I'm not denying that. But it's been before COVID. we've all been burnt out long before COVID. We've been so short-staffed. I don't know about you guys, but I get messages constantly, every day, all day, saying, come into work. We need you. Does everyone else get that? I'm still getting them now, being in Bali. Like hell, I'm coming to work. So Frenenberg, who was a psychologist back in 1975, his definition was it's basically symptoms of malaise, fatigue, frustration, cynicism. It's a good one. I know a lot of nurses that are quite cynical and it drives me nuts, but it's a coping mechanism or it's part of their personality. But it's making excessive demands on energy, strength or resources in the workplace. And the term was borrowed from other fields and applied to healthcare in the hopes of readily transferring the solutions that have worked in the other industries. So you basically applied it to people with PTSD in the war. And that's where burnout came from. And half the nursing workforce is experiencing burnout, believe it or not. Hard to believe, isn't it, really? There's your cynicism. With likelihood of personal consequence, job dysfunction, and a potential risk to patients. So our patients are at risk because we're not able to provide that quality care. Now, I take pride in my nursing. I love being a nurse and I love being there for patients. But when I can't, that's when I get frustrated and I get pissed off. And essentially, well, I don't always get burnout, but you know, it all accumulates over time. So statistics, and I'm sorry again, but this is about nurses. So according to, I don't know if you know, but the annual Mental Health Australia do burnout studies on healthcare industry every year. So it was clearly highlighted that so this was in March last year, and it was clearly highlighted that burnout was an issue prior to COVID in 2020, like I said. So it was 80% in 2020. In 2021, it was 86%, and then in 2022, it was 84%. So it's still hovering in the mid-80s. And then another study. Apologies, it's in America, but it's good to have a look at what else is happening in the world. In between 2018 and 19, so this is pre-COVID. They surveyed 1,688 nurses who completed 3,135 surveys, and 54% of nurses suffered moderate burnout, with emotional exhaustion increasing by 10% and cynicism, sorry, I can't say that word very well, scores increasing to 19%. So, and basically what Elizabeth was saying as well before, wherever she is, sorry, yeah, so it's always hovering about 50%. So how can we prevent it? Well, these are all easier said than done, in my opinion, but I'm willing to give it a crack if you are. So detaching from work, which is basically what we're doing today. So I didn't want to preach to you. I didn't want to tell you what to do because I don't like being told what to do. But these are things that you can do if this was what you wish to decrease it. So detaching from work, so you can, well, they do say play video games, but I don't know, sometimes they are just good to switch off or just chill out in front of the TV. You don't even listen, but you're just watching it. Go for a walk, a jog, a swim, play music. Choose a recovery activity program, so socialising during a lunch break. Or sometimes, you know, if you've got the space in your hospital or wherever you work, maybe sit under a tree if that's what you prefer. Listen to some music on your phone. Take that time out. So this can be positive, obviously, in helping stress levels when spoken about, and it depletes their energy at the end of the day if you don't talk about it sometimes. So emphasise high-effort recovery activities, so pursuing a new hobby. So one of mine is photography, like the photos that I had taken earlier. I did want to put you more, but I did want to put more on there, but I'm not very technologically advanced, so. What else? So take micro breaks. Now put on the toilet. You may think that's bloody crazy, but a bit of mindfulness on the toilet. I just like to sit there quietly just for a minute. Not that I'm doing anything else, not that you need to know. but just to have a bit, they have, at my workplace in one of the toilets, they have a sign of mindfulness, like when you're washing your hands, so making sure you're getting in all the grooves and blah, blah, blah. Finding a quiet place, like I said, choose an environment that's faster. Oh, I've already said that. Oh, no. So parking further away from your workplace, so walking to and from your work is a good time to, work your way up to work, work your way down. Taking breaks on time. So evidence showed that 55% of nurses feel guilty for taking breaks. Who feels guilty for taking breaks? Calling in sick even. We shouldn't. We're such good caregivers. We need to give back to ourselves. So look after yourself. So the impact is the lack of resilience in staff. So this increases burnout, but this does not contribute to staff turnover or retention. Staff are more inclined to seek employment in different organisations or seek employment in other fields of work. I was quite happy to go to Bunnings. Hell, I was happy to even pour a beer or make a cocktail. I wanted out of nursing at many points in my life. Senior staff are forced into early retirement and junior staff wanted to quit due to not feeling adequately supported. Patient safety is impacted and compromised, like I said before, and most areas in our healthcare nationally are significantly understaffed and overworked due to increased absenteeism, sick and stress leave. Now I'm going to go on to bullying. I'm going to go through this really quickly. Has anyone been affected by bullying? Yeah, I have, many times. Women, because we are quite a high proportion of women, can be bitches. Sorry, just saying. Fair Work Act states that bullying occurs when two criteria have been met. So this is when a person is repeatedly behaving unreasonably towards a worker or a group of workers at work. Their behaviour creates a health risk to health and safety. This behaviour may and it must occur repeatedly. So in the Fair Work Act, they do state over and over, they obviously repeat it because it is to be repeatedly done. So the behaviours, aggressiveness, intimidating, belittling or humiliating comments, spreading malicious rumours, teasing obviously, exclusion from work-related events, unreasonable work expectations, including too much or too little work, and expectations of work that's not within your scope of practice, displaying offensive material and or pressure to behave in an appropriate manner. The other thing I need to mention though, if you're being performance managed, that is not bullying, apparently. So the statistics state that 93% of healthcare workers have either experienced or witnessed bullying. That's huge, 93%. I think it's appalling. For a caring nature of nurses, we do a bloody good job of bullying each other. Of the new nurses who quit their first job within the first year, 60% quit because of the bad behaviours of their co-workers. The three main reasons, like I said, women, the gender imbalance, the forced hierarchy. This is phasing out a bit, so the physician, well, the doctors and the nurses, we were below, so we had to make ourselves look superior. So we had a sense of powerlessness and helplessness. A high stress environment brings out the best in some people and sometimes it just brings out the worst. So what can we do about it? We could talk to somebody, one of our friends, family members, talk to someone that you can trust and feel comfortable with talking with. EAP, I don't know if you guys know EAP, so your organisation will they often provide counselling to the workers or you guys. Or you can speak to the bully if you feel comfortable and appropriate to do so and confront them about it. And if this is not the case, then you can talk to your supervisor or manager. If it is your supervisor or your manager, you can go the one above. Find out who's above them in management. Speak to a work health safety representative, so know who that is in your place of work if you have one. Speak to your union. I don't know how good I'm sure most people are with ANF, is that right? Or with other unions. Check your organisation's policies. So prevention of bullying and harassment, organisational values, are these upheld? And the grievance and disciplinary action. Human values, ethics and morals. So values are beliefs that are purely personal and consciously acquired by personal experiences. And everyone's got different human values. I pride myself on my human values. I am compassionate. I love to be compassionate. And fair and equitable and with respect. Then morals are principles that people believe what is good and what is right, what is bad, what is wrong. And ethics explain a behavioural code that explains what is good and right and then what is bad and wrong. So similar to morals. Important thing, what is culture? What's your culture? So the term refers to collective behaviour patterns of a group of people. In other words, it's their way of life. So my way of life is not your way of life. But when we talk like we're networking with each other, we're all finding out where people live, their families, what they do, how their work is. A lot of us have spoken about work, and we've often talked about our families and our private lives. People have objects or rituals, may embody a person's culture, but essentially they're in people's memories and their consciousness. So it's something that we do that we don't even know that we're doing it. And people within a culture do things in a similar way because they have a common way of understanding life and their environment. We all have the ability to relate to each other. It's just a matter of getting to know people. And this is what I love about nursing as well, is getting to know who you're treating. What are they doing? I mean, obviously when you have the time, a lot of the time you just treat them and you pop to the next person. So culture safety is basically, it's on basically with Aboriginal and Torres Strait Islanders is what cultural safety is based on. So according to Williams, it's an environment that is safe for people. It's about shared respect, shared meaning, shared knowledge and experience of learning, living and working together with dignity and truly listening. How many of us actually truly listen? You know, I don't know how many people I go to at work and they go, "Oh, hi Em, how you going?" And they keep walking before you even say, "Oh, good, thanks." So truly listening is really, I think, is really important. The cultural framework to work which within may involve cultural connectedness, spiritual connectedness and social connectedness. I think in Australia our culture is lapsing sometimes, and I think we need to build that up within ourselves. So the ideal world culture, some of this might sound a bit wanky if I can use the word, but it sounds great in the real world. So credibility, so employee retention, overall workplace satisfaction, employees that recommend their company. How many of you say, "Hey, you should come and work with these guys, they're great"? Does anyone do that? No? Anyway. Motivated to give extra of work, honest and ethical managers. So respect, recognising that employees have a life outside of work, workplace flexibility, fairness, that goes without saying, belonging, accepted and valued as an employee, not just a number, but a person that's working in healthcare and giving so much of yourself. Welcoming new staff and embracing diversity, effective leadership, values and innovation. So the ideal teamwork, so in 2008, Baker and O'Malley have advocated that leading with kindness is effective in both optimising organisational performance and building high commitment workplace cultures. It's a moral duty if organisations are to both maximise wealth creation and honour duties that are owed. It improves clinical outcomes. It increases professional satisfaction, so everyone's happy to be at work and they love being at work. Provides crucial peer support. It stops the us versus them because we become a team and collaborative. We suspend judgment. So asking questions and inquiring is really powerful, and there's no such thing as a dumb question. Or sometimes maybe. Suspend judgment, value team integration, so clear understanding of the team roles and validating them individually, creating psychological safety, which is what Elizabeth touched on earlier, And final word, encouraging all members of the team to speak up. There's always one in the group. I'm always the one that speaks up, but there's always other people that are very quiet and deserve that respect too. So, final note, I just want to say thank you to all of you for being here. I'd like to sincerely thank you all for listening and taking the time to be here today. I would also like to acknowledge you all individually, really, for all your hard work, both past, present, and in the coming future. And if any of these issues have raised any issues for you, please reach out. And just a quick note too, sorry. There is a really good podcast called Not My Patient. It's quite inappropriate, very inappropriate actually, but it's very funny if you want to listen to it. It's colleagues of mine, so have a listen.
Let's hear it for Emma. So thank you very much, Emma, and to all our presenters for their presentations this morning. So now it's time for your reward. You got up early, you've learned something. So go out, enjoy Bali, take some photos. For those on the day tours, have lots of fun. For those on the sunset cruise tonight, behave. We found out that there was a EMS conference baby floating around last year from a few years back. So I look forward to hearing the stories in a year's time. So enjoy, guys. Have a good one. And we'll see you tomorrow at 2 o'clock here. Cheers.